Okay, so good afternoon. For a lot of you, you know me, my name's Dan Butcher, and for those people who are joining us on the video, welcome. What we're going to do today is to look for the next sort of hour and a bit at issues related to the immune system and build on that the material that we're going to cover later in the journey, looking at issues of when immune systems malfunction, and also as an example, we're going to look at HIV and AIDS, and we're going to have some input from service providers and also people actually living with the condition. So what we're going to do in terms of our objectives is to recap on some of the non-specific and the specific body defense systems. We're also going to consider how we actually, how these systems protect us. I think what we've got to remember is that while we're sat here quite calm and relaxed, some of us having something to eat and drink, listening to this lecture, our bodies are under constant attack, and we tend not to remember this. It's not a problem because most of the time we have incredibly well-developed defense systems that keep us safe. Like a lot of things, we kind of take it for granted, as long as it does the job that we want it to do. But it is an incredibly complicated process, multi-layered, and when everything's working, we're fine and funky. As soon as things start to break down, as soon as things start to undertake offensive rather than defensive mechanisms, then we start to see the pathology of a lot of the diseases that we're already familiar with. So we're going to look at the system and actually try and unpick why an understanding of the immune system and why a well-functioning immune system is so important. We're also going to look at what happens when that system fails, as I say, and we're going to use as our example the pathology, the staging, the testing and the transmission of HIV as an example, because this really is a useful way of understanding what happens when the system doesn't work as it should. Okay. So, I say we're going to start with a bit of a recap, so we're going to initially consider some of the non-specific defense mechanisms. And there are quite a lot of them. The first of all is the physical barriers, the stuff that keeps the outside out and the inside in. Our skin, and for those of you doing 135 next semester, we'll look at the integumentary system, we'll start to consider how significant it is. The biggest organ in our body. Again, we tend to take it for granted, although it's something that we will all check out. I think we spot issues with our skin much quicker than we spot issues with other parts of our body. Because we can see it, or most bits of it we can see. But it plays this hugely important process of making sure that that physical barrier to microorganisms is available to us and keeps us safe. However, once that system is breached, we can then fall back on multiple other types of defense mechanisms. So, things that you'll certainly be familiar with are at a cellular level phagocytes, these white blood cells which have a fantastic janitorial job. They truck around the system, they devour any foreign bodies, any damaged tissue. Engulfing it, macrophage is big eater. It allows the diseased tissues to be cleared away and the whole system to be kept reasonably tidy. This works provided the macrophage can recognize the self as self, and we'll talk about that importance of recognizing what's your own tissue and what's foreign tissue in just a minute. We also have something called immunological surveillance. Now this is essentially the actions of particular types of cells. Now, I don't know if Quentin Tarantino is ever going to do a film about the internal defense mechanisms within the body, but probably the best named cells in the entire body are the natural killer cells. They have this fantastic death on contact process. All they need to do is to touch a foreign cell, and certain processes are kicked in and it destroys these cells. So we have this whole series of natural killer cells which are patrolling the body all of the time, looking for foreign material. issues that we never appreciate, that are never sort of brought to our attention, we immediately see the natural killer cells deal with them. We have various other mechanisms as well. We have interferons. These are cytokines. These are chemical messengers which essentially interfere with the replication of viral tissue, and we'll see some of that in the later discussions. We also have something called complement system. Now, I'm moving through this at a reasonable pace, not because these systems aren't important, but because as a process, as a collection of systems, they work together. Each one has its own particular complexities. And in terms of nursing practice, we don't really need to know the ins and outs of the complement system, but we do need to appreciate that it isn't just one system we're dealing with. We have a multi-layer approach. So the complement system is a range of particular chemicals that there's about 20 of them, which actually coordinate a lot of the immune processes. They're involved in inflammation. They are responsible for triggering certain actions. And when we actually have an impaired complement system, we see broadly our immune system is compromised. And as we move down through this table, we see there are a couple of other things that are probably more familiar with us, or we're more familiar with, and things like the inflammatory response. Now, can you just quickly tell me, there are 4 cardinal signs of inflammation. Can somebody tell me what those 4 cardinal signs are? Or just one of them to start with. Swelling, thank you very much. Okay, so we have swelling. So why does swelling occur? Okay, you're safe because I'm stuck behind this desk. Okay? You know that normally I'd be up that stairs sort of checking out for answers. Okay, let's go for another sort of cardinal sign of inflammation. We have swelling, what else? Colour, redness, yes, fantastic. What else did you say? Heat, yep, so temperature. So we've got swelling, we've got temperature, heat. What else? Pain, fantastic. So that's the last one. Okay, and all of these are mediated by the body's response to tissue damage. It's all about the influx of multiple types of tissue, white blood cells, plasma, into an area of tissue damage in order to not only minimize ongoing damage, but also to offer protection, to dampen down any potential risks, and then be the starting point for tissue regeneration. And each of these things are sort of very familiar to us. We find that we use therapies to try and deal with some of the pain of inflammation and what have you, but actually it's an essential process. So when you have pain and discomfort because you've tweaked your back or you've got some sort of inflammation, that's actually part of the natural defense process. It's an essential part. We also have something called sort of a fever, which again I'm sure you're aware of. Fever, you might think, is a little strange that it fits within these non-specific defences, but fever is about adjusting our metabolic rate. What we've found is that when our body temperature goes up, our metabolic rate goes up, and that metabolic rate is important for enhancing this immune response and ensuring that we get adequate opportunities to deal with a threat. So these are non-specific. These happen all of the time. Okay? If we try to nail down where the immune system is, it's quite difficult. It's not quite as easy as the cardiovascular system. You have a heart, you have blood vessels, and we can actually imagine that. The immune system exists because it exists in lots of different layers. It's not quite so easy to pinpoint it. So we look to see our transport mechanisms really as the basis for our immune system. Because this is a gross idea, when in actual fact most of our immune function is at that cellular level, much, much smaller. I will just draw your attention to the thymus gland, which sits just behind the sternum, and we'll see why that's important in just a moment. Because this is a location for some of the development of these cells that we're talking about, the cells that actually cause this immune system development. So if we look here, we'll just look at how lymphocytes derive and change over a course of time. So lymphocytes, white blood cells, they will exist in the bone marrow. They develop from these hematocytoblasts, and depending on where they then are located, they will be exposed to a different environment, and that environment impacts on the way in which they derive and the nature of the characteristics that they show towards the end. So if they stay in the white bone marrow, or the red bone marrow, sorry, you'll see these cytoblasts become lymphoid stem cells, and potentially will develop into B cells, and we'll talk about B cells in a minute, but they will also form our natural killer cells. Now, we've already talked about our natural killer cells, these that have particular opportunities to kill on contact. Doesn't matter what it is, non-specific. So we see within this first part of our stem cell development, we see a non-specific response, and we also see what will turn out to be a very specific immune response. If, however, our hemocytoblast transfers to the thymus gland, it is then exposed to thymic hormones, and they change the way in which it will develop. And what we see here is these thymic hormones change it. Rather than a B cell, it actually turns into a T cell. And I'm going to explain what B cells and T cells are in just a moment. So we can see from a very, very similar starting point, based on the location and the environment in which cells are exposed to, they will actually divide into or derive into very different beings, very different entities. Now, I don't know about you, but I find that absolutely amazing. And at each twist and turn of the immune system, you realise just how complicated and how stunning it is as a system. But like anything, the more complicated it is, potentially, the more dangerous it is when it goes out of control. And we'll see that in a moment. Okay, so I'm just going to ask you for a moment to explain what you see on the screen to the person sat next to you. Just ponder it for a little bit, see what bits jump out at you, and then tell the person sat next to you. Okay, so it's really good to see lots of waving and pointing and gesticulating to this bit or that bit or what have you. So what strikes you about this particular diagram, and what points jump out at you?
It's two different parts.
Two different parts. Okay, so which two different parts are you thinking out specifically? Because we can cut this cake in lots of different ways.
In the sense that you've got like the antibody side and then the cell mediated.
Okay, so we can divide it into two parts by having the antibody-mediated immunity, or we can have the cell-mediated immunity. Yeah, excellent. Now I say we can cut it in two different ways because we could also have the adaptive immunity, which is the bottom section, and then the non-adaptive or non-specific approach at the top. So there are different ways of looking at this. But yeah, that's fantastic. Great. Anything else? Come on, you can't leave me just standing here like a lemon. You have to give me something. There's a bit of a circuit to it, isn't there? Yeah? So you can see the way it's sort of all linked in. So we don't have a closed system, but we have a continual relationship between each part of the system and something else. Okay? There's always a preceding issue, and that then triggers a following response. And that's really very, very important. Okay? What else? It's complicated, yeah, I'll go for that. It's complicated, yeah, for sure. It is, and that's part of the reason why I wanted you to sort of sit and just ponder it for a while and see if you could explain it, because in actual fact, it looks quite complicated, but there are elements that we can start to understand. So we can already explain what we were talking about earlier on with the non-specific defense mechanisms. Yeah? And then we also recognise that our non-specific and our specific defence mechanisms work together. One is likely to start before the other. Which one is there, ready to go immediately? The non-specific. The non-specific is there, primed, ready to go. It doesn't need a great deal of setting up. It doesn't need a great deal of preceding activities. As I've said, with things like the natural killer cells, they just need contact. Bang, job done. Okay? Whereas our specific defense mechanisms take a little bit more time to get going, to get revved up, to get attuned. Once they are then triggered, their response is massive. Much, much more. Much, much greater. So we have this fantastic two-stage process. And what we're going to do is we're going to talk through the adaptive processes in just a little bit more detail. And then we'll probably come back to this, because there's something that I would just very quickly draw your attention to, because it's very relevant when we're looking at HIV, and that is what's sat right in the middle of this particular diagram. It's something called helper T cells, particular types of cells which have directing function and actually tie our cell-mediated and our antibody-mediated immune systems together. Okay? Now, we can find susceptibility at all levels of this process. But unfortunately, and we'll talk about this, as I say, when we're looking at HIV, some diseases target what is, if anything, the weak spot, the coordinating centre. Okay, so let's just have a look at what happens when our bodies are invaded by foreign material. How do we deal with this? What actually happens? Well, here we've got a slide which shows what happens with an infected cell. Okay, now, as soon as you see at the top here, some viral material enters the cell through the membrane and then is into the cell structure. Now, what will happen is immediately there will be an attempt to try and break that protein down. And the body's very good at doing that. Anything that's not recognised as self is potentially broken down. And within the endoplasmic reticulum, or in the Golgi bodies, we'll see these particular classes of protein, MHCs, major histocompatibility proteins or complexes. Different types of them, and essentially their job is to present. It's to take elements or fragments of antigens or viral properties and actually present them at the cell membrane. So what we'll see here is the viral material comes in, we see this protein takes hold of a part of that foreign material and through the transport vesicles actually approaches the surface of the cell and then stands on the edge of the cell and basically holds up this piece of protein. Okay? Saying, look, I've been infected as a cell, this is what we've been, this is our trouble, this is the problem. Okay? So this is how an infected cell will deal with its infection. We then have this presentation. Okay? You'll see that there are other elements in this process, but I'm just going to show you one other method of presentation, and this is what happens when a phagocytic cell actually engulfs a piece of foreign material. And you'll see there's very similar sorts of processes occur. Here we have a lysosome. So actually we see that this pathogen has penetrated the cell. We'll see some sort of dangerous chemicals which are actually in these lysosomes destroy the infected material. Again, we end up with debris of the foreign material. We have a slightly different class of protein that again takes elements and presents it at the cell surface. So in both cases we end up with the cell presenting foreign material to the rest of the body. What happens then? Well, we've got different types of T cells. There are three main types of T cells. Remember, these are the cell-mediated immunity. The first one is referred to as the cytotoxic T cells. Cytotoxic meaning they actually have the potential to create damage. And we have these T cells floating around in our body inactive most of the time. Now what happens if a T cell comes across some sort of tissue that's presenting a foreign material on its surface? Either it's been infected or we have some sort of damage. What we have here is an inactive cytotoxic T cell which establishes a bond with the infected material through this major histocompatibility complex protein. We have something here called co-stimulation. Now, I'll just very quickly draw your attention to the fact that sat next to this connection between the two cells is these two little dumbbell-shaped proteins called CD8. Now, these are cell surface proteins which often lend their names to different types of cells. Okay, so cytotoxic T cells typically are also known as CD8 cells. Okay. Now, we have this connection, we have some co-stimulation, and the result is that we no longer have inactive cytotoxic T cells, we now have active cytotoxic T cells. They've been switched on. So we've got some sort of recognition, and now we have some activation. So what do these cells do once they've been switched on? Well, they replicate. They divide, and we end up with different types of T cells. We get some memory T cells, which are ready for next time. So we immediately are thinking into the future. What happens if we see this material again in the future? Well, we'll start building up a defense right now, right from the beginning. A very, very forward-thinking system. The rest of these cells, as they divide, are active cytotoxic T cells, which have the capacity, as I say, to actually create some damage. So the next time that they come across a cell that is presenting foreign material that they recognize, these things go overboard completely. Once they're activated, they just exude a whole load of toxins, cytokines, porphyrin, all of these chemicals which essentially destroy the cell structure of the target cell. The result is the cell that's been attacked dies off. Its outer surface is no longer integral, and therefore it can't sustain itself. Now, this obviously isn't just happening once, this is happening millions and billions of times in all of these cytotoxic T cells. So we have a fantastic response to this presentation of foreign proteins. We've also got our helper T cells. Now, they're doing something very similar. Okay? Now, remember I told you about the cell surface proteins for cytotoxic T cells are referred to as CD8 cells. Well, I'll just draw your attention up here to the proteins on the surface of helper T cells. They're slightly different, and they're referred to as CD4 cells. So you'll quite often hear that CD4 and helper T cells, they're sort of used interchangeably. Okay, essentially they're talking about the same sort of thing. And we have a similar sort of pattern here. We've already seen presentation. We now get this process of activation or recognition and activation. So when we get some activation, again, we get this connection between the infected cell and our helper T cell. And a very similar process that once this helper T cell has been activated, it immediately goes into overdrive and starts dividing. Once again, setting up some memory cells for future and some active helper T cells whose job it is basically to spread chemical messengers in the form of cytokines. Now, these cytokines, you'll see, are hugely important for triggering the antibody-mediated immunity. So this is why the helper T cells form that link between cell-mediated and antibody-mediated immunity. Okay. So just as a quick recap, these are the different types of cells. Now, I haven't mentioned suppressor cytotoxic T cells because our immune response essentially is something that we want to focus on. We do also have to switch it off. So there are a class of T cells which have a suppressor activity, and when their numbers get to a certain level, they start to outnumber the cytotoxic T cells. We start to see a dampening down of the whole process. And that's really important. We don't want to be on fire all of the time. We don't want the system to be raging away. Well, at some point, we want to be able to slow the whole thing down, conserve our immune energy so that the next time the system can actually respond appropriately. So each of these cells has a very specific role. Okay, now, here we see the link between our T cells and our B cells. And this is something that you may well have addressed in previous modules. I just want to recap it for you. So at the top here, you can see the antigens, so this foreign material, picked up by an inactive B cell. Now you'll see B cell is, on its surface, is a whole series of proteins, antibodies. Okay? But the antibodies that already exist may or may not have the capacity to do what we need them to do. And in addition, the cell is inactive, so nothing's really going to happen. But as soon as we see an established relationship between the antigens and the antibodies on the surface, we then see a binding process which ultimately sensitizes the B cell. It recognizes there's something in that antibody on the surface. Hang on, guys, we're just about to go here. So it's kind of switched on, it's ready to go. So as we move down, we now see our friend the helper T cell have another role to play. Not only has it shared these chemical messengers, but it's also playing an active role in changing our sensitized B cell into a very active B cell. And the cytokines help with that. Okay? We've got this established connection. We've also got these chemical messengers which are saying, yeah, go on, go on, go on, go! and the whole system really takes off. Okay? So we have these various fail-safes, things that have to happen, but when they do happen, and they've all happened, bang, the whole system takes off, which is exactly what you want. If you're fighting, I'm no sort of military sort of strategist, but if you're fighting a war, you want to know who your enemy is, you want to get ready for it, you want to build up all your resources, and then when you hit hard and eradicate. And that's exactly what the immune system has the capacity to do. So, once we have our B cells ready and activated, again, like most immune cells, the first thing they do, let's replicate. Let's get lots and lots and lots of us out there. Some take the version of these memory cells, ready for next time, but our activated B cells differentiate into plasma cells. And these plasma cells essentially are factories for antibody production, and they go into overdrive. They're just pumping out billions and billions and billions of antibodies out into the system. Okay? So we see a link between our cell-mediated immunity and our antibody-mediated immunity, and a lot of it pivots around the functions and roles of the helper T cells. So, we've got all these antibodies floating around. What are they going to do? Okay, well, there are different types of antibodies. Most of them are referred to as IgG. It's a particular type of protein. We also have a couple of other types. You can see D and M and the A at the bottom here. And I'm just also highlighting that IgE is also quite important. It's one of the antibodies that's responsible for our sort of anaphylaxis and an allergic response. Okay? But most of these are IgG. These are the antibodies that offer resistance to viruses and bacteria and what have you. So these are our primary productions. What do the antibodies do? Okay, so this is what they do. They do a variety of different things. These rather strange Y-shaped looking proteins have the potential to do all sorts of things. First of all, what they can do is they can neutralize the binding sites of viruses and bacteria. So essentially, they stick to the cell, whatever it might be, the virus, the bacteria, and stop it from interacting with the local environment. They actually stop any communication and effectively neutralize by swarming around and limiting any of those binding sites from actually having an action. If the cell can't actually communicate, if it can't bind with anything, then it can't do what it needs to do. It can't replicate, it can't secure more proteins, it can't continue its infection. So the antibodies work in that particular way. They also have this neat sort of role of aggregating, clumping together, and basically tying together whole sections of viral tissue or bacterial tissue, limiting the impact, which the body's non-specific defense mechanisms are then able to target. Because they're slow moving, we can deal with that. Something's not quite right. It's recognized as non-self, and it's dealt with. But the antibodies also do other things. They stimulate inflammation. They are involved in the activation of the complement system that I mentioned earlier on, that series of chemicals that are essential for communicating this process. And they also serve to draw in those phagocytes. So once the antibodies have actually stuck things together, there's then a tendency for these phagocytes to be drawn to high densities of antibodies, and therefore they're able to target their phagocytic activity. Okay. Now, I should just say all of these slides are available on Moodle, and you'll be pleased to know one of the very few times that I haven't messed around with them just before I came into the session. Okay, so they're pretty much as they were on the Moodle site. So you should be able to print them off and do whatever you need to with them. Okay. Any questions from anybody in the room or anybody on the video cast that you have, please just let me know. I'll be more than happy to go on for hours about this sort of thing. But if you do have any questions, just let me know. Okay, so where are we going next? Well, now we're going back to our original picture. So I'd just like you to take a moment to have another look at it. Okay? Just reassure yourself how the things that we've just talked about actually fit together, and just get a sense of how significant this sat right in the middle really is. Okay? Can I just check, have we got any questions so far? Okay. What do you think generally?
You're going to cover the self and non-self stuff later.
The self and non-self stuff. What exactly do you mean?
What it is, what's the impact, how it takes place in the body.
Okay. I'm not going to go into that in a huge amount of detail, but what we have is, because of the actions of the major histocompatibility complexes, the body's actually able to, is exposed to self fairly regularly. So anything that isn't self is then deemed to be non-self. But that system can go haywire sometimes. And this is where, in fact, you lead me quite nicely onto our autoimmune conditions, because this is what happens here. So there's a lot of conditions, as you can see, when this system works, it works brilliantly. It keeps us safe, and every one of us in the room is here in no small part due to a functioning immune system. At various points in our lives, even though we may not have appreciated it, we have been under attack from viruses, protozoa, pathogens across the board, and yet our system deals with it. And it deals with it very effectively. But what happens when the immune system doesn't recognise self? I'm not going to go into the exact details of how it does and how it doesn't recognise self. Safe to say that some of them just aren't understood. If we understood them, then we'd know why diabetes is what it is. Yeah? Because we're all familiar with diabetes. Diabetes is an autoimmune condition where, for some reason, the body destroys its own pancreatic cells. Okay? Now we have a series of conditions here. Rheumatoid arthritis has an autoimmune link. We also have systemic lupus, where tissues in the kidneys, in the brain, in the blood vessels are damaged. Multiple sclerosis, where the linings of nerve vessels or nerves are damaged. We have thrombocytopenia, where platelets aren't recognised as self and therefore start to be damaged. Meniere's disease, any of you come across Meniere's disease? A few of you, yeah? Which organ does that affect? Ears, that's right, and balance. Chronic hepatitis, obviously, situations in the liver. Myasthenia gravis, the neuromuscular junction is targeted, and therefore muscle weakness is a major problem. Now, all of these conditions are the result of the immune system getting it a bit wrong. Yeah? But obviously, because it's such a potent system, getting it a bit wrong actually has massive consequences. Yeah? So these are the conditions that we are dealing with. I just sort of draw your attention back to diabetes. Diabetes is a big deal, and it will be through most of your careers. Often we talk about type 2 diabetes because that is much more about lifestyle. That's a chronic illness long term. We are very clearly talking about something different when we're talking about diabetes type 1. Okay? And we have to sort of get that in our heads, that diabetes type 1 and diabetes type 2 are in no way even similar. It's just the fact that they affect the particular organs or particular cells. But actually how they come about is a radically different process. We can also see that in terms of allergies, we also have hypersensitivity reactions, we have immune complex disorders, a whole series of things that associated with allergies. And I know that tomorrow one of my colleagues is going to come talk to you about allergies and anaphylaxis, because again, that's when it goes completely wrong. And we're also going to talk today about immune deficiency syndromes, so where the immune system actually is compromised in some way. I will just briefly talk about about allergies though, and what you'll see here, and you'll read it quicker than I'll describe it, so I'll just let you read it, the process by which allergies develop. Okay? Now again, we have this similar process that we've seen before. We see an initial response, which is quite measured, quite controlled, and then subsequent exposures to allergens creates a massive, and I mean massive, response, which ultimately can cause not only the offer protection that we need, but if we're talking about an allergy, can cause the problems that we see. Issues of allergies have become increasingly a problem over the last sort of 30, 40 years. And just some statistics for you. There's 21 million adults in the UK who suffer from one allergy or another. And I would guess in this room there's going to be a fair proportion of you who would identify that you have an allergy. You can see that there's a whole series of potential problems there: pollen, dust mites, mould, cats and dogs, allergic to cats and dogs, yeah. Eggs, food. We're seeing more and more food allergies starting to become a problem. And if this is just a sort of mild allergy, you can't be in the same house as a cat because it makes you sneeze, well, that's fine, you deal with the cat. But in some circumstances, not sort of like deal with the cat, favourably deal with the cat. But some of these things are going to make a big difference to how people live their lives. Okay? And this has become more and more of an issue. And we get down to the bottom here. Thankfully, anaphylaxis is not a major problem, but when it does happen, every year, it kills 20 people. Okay? And this is just an allergic reaction. I say just an allergic reaction. But what I want to illustrate is that this is a system doing exactly what it's designed to do, just goes completely overboard, and it can have this sort of effect. So, I just want to check, or just want to ask you, why do you think we've got this situation today that we probably didn't have sort of 40, 50 years ago? Why is everybody now allergic to something? Any ideas?
I think it's because when we get overboard about cleaning and about everything has to be antibacterial,
Okay.
and children aren't allowed to be exposed to anything, so you don't build up those.
Okay. And that is probably, did the rest of you hear that? Okay. So the suggestion was that actually we now have a situation where we know so much more about bacteria and the actions of bacteria, and we have so many more chemicals available to us to actually control the situation, that actually we now might find that we're going a little bit overboard, that we are no longer exposed to things that we would, our sort of parents or our grandparents would have been exposed to in their childhood, that we now get much later in life before we're exposed to. And then potentially we find out that actually it creates an extreme reaction. Okay? We're also finding that we are processing so much more of our food, so the possibility that that processing is actually having an impact on the amount of food allergies that people are having. The bottom line is nobody really knows why this is happening. The simple fact is that it is. And so we need to be aware that this is part of the care that we're going to have to provide in the future. And again, it's our immune system doing what it should do.
Is it that it's being recognised more? I think a lot of allergies, people probably just got on with it. It wasn't ever actually taken as a problem.
Yeah, that could well be right. So just for everybody else, the notion that we probably recognise a lot more than we did a number of years ago. In the past, people might have just got on with it and not necessarily recognised it or tagged it as an allergy. And I think that what that's doing is illustrating the nature of the situation as a whole. There are multiple factors. Okay, so what we're going to do now is we're going to move on to consider an example of a compromised immune system and what actually happens. Okay, so we're going to use as our example HIV, human immunodeficiency virus. Now, I mentioned earlier on CD4 cells, okay, and these are the helper T cells. These are the things that are principally damaged by the human immunodeficiency virus, which is an RNA virus, a retrovirus. Okay, so the information is carried as RNA, not as DNA, and we'll show you the process of that in just a moment. Okay, but these infected cells are essentially, rather than being destroyed, they are commandeered. So they are turned into factories for the viral process. So not only does our immune system, which is there to protect us, not only has that been compromised, but it's almost been turned around and used against the sort of us or the host. And you can see how potentially dangerous that can be when we see those autoimmune conditions. You know, an immune system that's not targeted quite right can have quite a damaging effect. So we find that not only are they used to produce the viral material, ultimately these cells may also be destroyed. The point at the bottom here, untreated infection eventually leads to severely compromised immune system. Now, HIV has been around, we've known about it for a good many years. Our knowledge about what it is and our attitudes to it have very definitely changed over the course of that time. And we're very lucky in the UK that actually there are very few people, I'm not saying it doesn't happen, but there are thankfully very few people who get to the point where their immune system is so compromised that they are then dealing with what's referred to as advanced infection or acquired immune deficiency syndrome, so late stage HIV infection. We have processes, and what we've seen is that as a result, HIV is shifting and is now much more a chronic illness that people are living long term with. Now, 20, 30 years ago, it was looked at very differently, and society looked at it very differently. I think we've got to appreciate that that's still out there for some people, okay? But we need to appreciate that this is essentially a chronic illness, because we are very lucky in the UK that there are processes for actually dealing with it and managing it, and we'll show you some of those in just a moment. As I say, if it's left untreated, in certain parts of the world, we have it developing into acquired immune deficiency syndrome. Now, syndrome is a collection of presenting diseases, okay? Rather than one particular thing, it's a particular package which tend to go together. So if we look here, we'll see that there are a series of, they used to be referred to as AIDS-defining conditions, things which you don't generally see in most situations. People don't tend to have these infections. So we see here pneumocystis pneumonia, cryptosporidium. TB is, we know, because we looked at it earlier in the module, is developing over the last few years. It wasn't a big issue in the UK, and gradually over the last few years it's become more of an issue, and thankfully we're sort of starting to win that battle again. Okay, but when you take it in combination with all of the other stuff, including something like Kaposi's sarcoma, so a skin cancer, which you very rarely see, not particularly pleasant, and toxoplasmosis, something that I was interested to read that a third of us will have toxoplasmosis as a parasitic infection. a third of us will have it at some point in our lives anyway, but it doesn't cause us problems. However, when you've got a severely compromised immune system, then it starts to cause problems, then it's diagnosed, and therefore it forms part of this pattern of advanced or late stage HIV infection. Okay, now, this is really important, okay? And I'll just read this out to you. Now, you're reading it as well, but I really want to underline it. As far as viruses go, HIV is not an easy one to pass from one person to another. The virus has to get out of an HIV-infected person's body and into the bloodstream of someone who does not have HIV for that person to become infected. Okay? Now, this information has come from the Terence Higgins Trust. Now, Terence Higgins lent his name, or gave his name, to a charity, a trust, which has, certainly in the UK, worked tirelessly for HIV education, developments, and is a really useful resource. So if any of you are interested, I'd certainly encourage you to have a look at the Terence Higgins Trust website. The massive amount of resources there, not only for people who need to know about HIV infections and spread, but also for healthcare professionals. And just some figures. The figures always lag us, unfortunately. It always takes time for them to sort of come together. So what we can see here is the number of people living with HIV worldwide, from 8 million in the 1990 to 35.3 million in 2012. Okay? Now, the figures say one thing. Quite obviously, there's a massive increase over a period of 20 years, from 8 million to 35 million. Okay? But what I want to just target you onto is that word there. Yeah? People living with HIV. And that's hugely important. Okay? That might not have been the case 30 years ago. Okay? But it is the case now. People are living with HIV. I'm going to show you some figures. Some of these might seem a little contradictory, but in some ways they give us a sort of real hope, and other times they give us a sense of just how big the issue is for healthcare professionals to deal with this situation. So these are all global figures, okay? We do have to appreciate that we are very lucky in an advanced Western society with ready access to treatments. This may not be the case across the world. We are a relatively small island. When we look across the world, we look globally, we might see that the impacts of other parts of the world make a much bigger difference on these figures. So these are global. I'll show you the UK figures in just a moment. But what you can see is that there is a bit of a steadying out globally of people living with HIV across the world. Down here, actually, this is new infections. You can see that it's starting to go down. In fact, it's been going down for a little while now. That's got to be a good thing. How that's happening, why that's happening, there are various sort of reasons for that. Thankfully, people now know so much more about HIV. They deal with it in a completely different way in most parts of the world, not everywhere. But that's got to be a good thing, that we're actually seeing the number of new diagnoses going down. Okay. We're also seeing a tailing off in the number of people across the world who actually die from AIDS. Now, this is the advanced late stage. Okay. So again, we're seeing an increase in treatments. People actually, there's a much better awareness of how this is treated. Availability of drug treatments is greater. So we're seeing this start to tail off a little bit. Okay. If we look at the situation in the UK, we can see similar sorts of patterns. We see the diagnosis sort of coming down. There's occasional blips, but we do see a general trend coming down. We see HIV deaths and diagnoses starting to drop as well. So the sort of headlines are actually, this is good. The numbers are dropping. But then when we start to look and break down where our targets are, where we need to be much more active as healthcare providers, we start to see this. So just for a moment, just have a look at this. Have a look at what this is telling us. Does anything strike you about that diagram? Say that again.
It's more sort of the middle to the older age of the population that is the sexually active that are the most newly diagnosed.
Okay, so we're seeing new diagnoses in particular groups. And if we look, we'll see in our 25 to 34-year-old group, the new diagnosis is going down. That's got to be a good thing. Yeah? You think about the health education, people who are 25 to 34 have been getting the message about safe sex practices and about HIV for a good period of time. And let's hope that message is getting through. Okay? Where we start to see increases, this sort of pale blue line here, this is we're seeing a steady increase here over time. This is our 50 plus age group. Okay? Now, why is that happening? Well, there are some possible reasons for it. A tendency to think that, okay, maybe I'm not susceptible, that this is a young person's disease, that this is, you have people in relationships, longer relationships, maybe come to an end, and therefore they're back out, sexually active, but have never dealt with or never thought about safe sex practices in the past, and then find that they're putting themselves at risk. So we're seeing differences in our society in how people are dealing with our message, dealing with the sort of safe sex message. I talked to you right at the very beginning of the module about different health education and health promotion processes, models and theories and frameworks. And I really hope I got across to you that we have to do more than just tell people, this is bad for you, don't do it. Yeah? Which is very easy to get into. We need to be much more savvy and think about the people that we're working with. What are their needs? Because the needs of a 25-year-old are very different to the needs of a 50-year-old when it comes to safe sex and sex education messages. But don't think that people who are 50 aren't having sex, aren't putting themselves at risk, because it's still happening. Okay? So, we've got some real issues to sort of get our heads around there. The Terence Higgins comment suggested that it's actually quite difficult to pass on this infection. And what we've got to recognise is that that's because there are very specific mechanisms for disease transmission. Okay. Now the reason I'm putting this up is because thankfully nowadays people have let this idea go. But in the early days of HIV, there was all sorts of rubbish about how the infection was spread, including through urine, saliva and sweat, which is a load of old codswallop. But we had to learn what HIV is over a period of time. So we do have very specific processes. The result is that transmission falls into three principal categories. So we have intercourse or sexual activities, mother and baby, or some sort of blood-to-blood contact. Okay. What I'm going to do now is I'm going to show you a short 5-minute video which talks about HIV replication. Okay. It's commentated by an American gentleman who's got a very engaging accent. I kind of I've listened to it lots of times, and there's a potential it might make you want to drop off. Okay, but try and hold on to what he's saying, because what you'll see is the complex processes that are involved in this replication. But it's also a really useful video because it shows that at every point or every stage of this replication, there's also an opportunity to target some sort of intervention, some sort of treatment, which is why HIV treatments are never one tablet. They're often a multitude of approaches. So I'm just going to show you that for a few moments. Those of you watching on the video, you can just follow the link. Okay, so what I would suggest, the chap who narrates that is a fantastic and obviously very, very knowledgeable, but don't worry about GP120 proteins and all those sorts of things, okay? Actually, what you might find quite useful is watch the video with the sound turned off, because what you'll see is the actual processes, and I think you'll probably understand the processes a lot more. And obviously, big chunks of viral protein crashing into each other does not make that rather nice resounding sound. But do have another look at the video. As I say, don't worry too much about some of the complexities of the language that they're talking about. And what you might also want to do is have a look at the slide here, which essentially is that whole process captured in one particular slide, with each of the therapies or treatments actually identified. So you've got integrase inhibitors, you've got nucleotides and what have you. All of these illustrate the way in which this is a very complicated process, a very complex process. The value of it being complicated is that the more complicated it is, the more opportunity there is to get in the way and disrupt it. And that's essentially what multi-regimen drug therapy is about trying to do, is interrupt that process as regularly as possible. Okay? What it does also highlight is how the medicines are there, and they're only as effective when they're actually being taken on a regular basis. So, we've now got a sense of where some of our key measures come from. So, if somebody is infected with the HIV virus, we're going to, over a period of time, develop something called a viral load, which is the amount of replicated viral material. You can see that by hijacking the helper T cell, the HIV virus is targeting one of the susceptibilities of the immune system, but also turning it to its own advantage. So it then becomes a factory for this HIV material. As I say, thankfully, drug therapies are now taking it to the point where a lot of the time people will find that their viral load is very, very low indeed. And that's only got to be a good thing. But viral load does give us a useful indicator. It's a measure that's taken on a regular basis. The reason that I'm talking about it is because I know that our guests will mention viral load and its significance in just a moment. So we can use it to identify diagnosis, sort of through antibody testing, but also prognosis, prevention, and we can also look at the sort of the therapies that are being used. Viral load will make a difference. So essentially what it does is it gives us this clinical picture, but it's only half the clinical picture. The viral load is one key element. The other key element is the actual existence of healthy helper T cells and whether or not they're available. So we'll actually see these two things quite often quoted together, your CD4 count and your viral load, because they are related. I'll just sort of show you how they're related. But I'll just point out that after exposure, and this is the material that sort of comes straight from the Terence Higgins Trust, is that after exposure there are things that can be done. And up to 72 hours there's something called the post-exposure prophylaxis, which essentially is using versions of the treatment modalities for somebody with a confirmed infection in order to try and minimise the establishment of the HIV infection. Okay. Now, what I would just say at this point is post-exposure prophylaxis is just that. It's prophylaxis. What's got to be something that we bear in mind for the people that we care for, actually not being exposed, taking preventative measures in advance is much better than having to take these medicines. Okay? So the use of condoms, the minimization of the risks from blood-to-blood contact, these are things that we need to be sort of sharing with people who are susceptible. And they're not the people that we might immediately think, you know, the sort of irresponsible teenagers who have just found their sexuality and are out there putting themselves around, although that might be part of the issue, we might also be dealing with the 50-year-olds entering new relationships and needing to sort of understand that actually they are at risk as well. So we've got to be a bit more creative in our dealings with this. Okay, CD4 counts, as I say, sort of an indicator of the number of helper T cells. Now these are, I think Sue will sort of maybe mention this, but often it gives an indication of the severity of the infection. Obviously, the helper T cells are a measure of how healthy your immune system is. So if we measure the helper T cells, we've then got an indication of the severity of the infection. Now this is used, I think, a certain amount in the UK, but also across the world. They'll be sort of measuring helper T cells or CD4 cells to get an indication of the severity of somebody's immune compromisation. But we do see changes, and we do have to be aware that when we're making these measures of CD4 counts and viral load, that they are related, and depending on where this person is on their health journey, these relationships are going to differ. So soon after infection, we're going to see a rapid increase in HIV viral load. We're also going to see a decrease in the helper T cell levels. But what we'll also find is a levelling out, a bit of a levelling out at certain points. I'll just draw your attention across the bottom here to the various sort of stages. So after a primary infection, we'll have this period where somebody is asymptomatic. And this can be a particular challenge. So somebody has the infection, but is not symptomatic. Okay? Which, as a result, means people may not adjust their behaviours. They may consequently put other people at risk inadvertently. And I think with the scenario that you've been given, you might see how this situation can sort of come about. This, bearing in mind, is if the situation is not treated. Okay? Now, thankfully, this divergence of viral load and CD4 count essentially is if there is no treatment. More often, what's going to happen is we're going to see some sort of levelling out, and ultimately, we'll see the viral load start to drop and the CD4 count come back up again. Okay? So we'll actually see this diagram, much more of a pattern, and this viral load starting to come down. I just very quickly want to talk to you about HIV testing, because obviously, bearing in mind this relationship between CD4 counts and viral loads, it means that testing happens at various points, and we have to understand that it's not just a case of take a test, get a result, that's it. It is what it says. We have to interpret those results. So there are various types of tests, and there, I think, what I was reading last few weeks, we're now on the 4th generation test. Sue will confirm if that's still accurate. Okay, so we're on the 4th generation tests now. And these typically measure antibodies. But bear in mind that the antibodies have to be produced. They're not immediate. We know from our first part of the session that we have to sensitize the system. We have to then go about producing these antibodies. So they're not there right from the beginning. So there's no point testing straight away, or we can test straight away, but we won't necessarily see the antibodies that we're looking for. So what you often find is that there's a period where testing isn't really going to tell us very much, and that's come down and down and down and down. I think where we're at now is some of the rapid HIV tests can be accurate or give you an indication no less than 26 days after exposure. We're still talking about quite a period of time. Yeah. So helping people understand the significance of this. It's not about exposure one day, get a test the next day and know for sure. Unfortunately, it's a little more complicated than that. Now, it used to be there was a programme on BBC Three that always coincided with this particular module, and it was about a sort of a gum clinic, genitourinary medicine clinic in Manchester, and it followed people through. Absolutely fascinating. I think occasionally it pops up on the BBC iPlayer, if you ever get a chance to see it. And if I find any details of it, I'll certainly post it on Moodle so you can have a look. These are everyday people's life stories in relation to how they deal with the testing, their own sort of behaviours and the consequence of infections and what have you. Very, very interesting. And if you're thinking that that might be some area that you want to work in the future, certainly worth having a look at. Okay. So we see a period of time that we have to sort of consider. So what it means is that our results have to be interpreted. I'm going to be finishing in the next sort of 5 or 10 minutes, okay, so that you get a bit of a break. I appreciate I've been going on for a bit. So if we find that we actually have an antibody test and it comes back positive, then that's it. We know that. You know, the antibodies are there, so there's been enough time for the body to actually produce the antibodies. They've been detected. The HIV virus is there. This is where it gets a little bit twisted, is unfortunately a negative test does not mean a negative, because obviously the body takes time to develop those antibodies. So there will be some subsequent testing that has to go on over a period of time to be able to establish whether or not a risk has actually been turned into an infection. Okay? And this is why there's an awful lot of very, very capable, very skilled practitioners working in GU medicine, supporting, encouraging, undertaking really detailed assessments with people to establish whether or not they've been at risk or not. Okay? Great opportunity for sort of career development in that sort of area. Lots and lots of things, and it's just going to get more and more. So if it's something that you think you might be interested in, you can very easily make your career in just this clinical area. It will use so many of your interpersonal skills at such a high level.
Is 3 months reduced to 26 days?
So again, I think that, yeah, what I understand is that the sort of the rapid tests now, they can measure exposure no less than 26 days, but previously it was sort of up to 3 months. Yeah? Okay. Here we go. So this is, if somebody has the HIV infection, isn't treated, isn't sure, there's a period where ultimately the infection will start to show symptoms. Not always, but it might start to show symptoms. I'd just like you to have a look down that list and tell me what really jumps out at you. Sorry? It could be absolutely anything, couldn't it? Yeah? Just, I'm really pleased, I'm not trying to scare any of you, okay? Just have a look down that list and just ask yourself, how many of those have you had in the last 6 weeks? Okay? It's so common. There's nothing, absolutely nothing, that stands out about that list. And that's possibly one of the problems, is that the consequences can easily be missed. Even when they do manifest themselves, it's too easy to put them down to something else. So this is why understanding the nature of somebody's exposure is really quite important, and why Gum Clinic staff spend so much time doing really detailed health histories and exposure risk histories. Yeah? Because this in itself won't tell you anything. Okay, now just like cancer, and I know when we were looking at lung cancer the other week, we talked about staging. There's also a staging system for HIV. I know that this is absolutely tiny, don't expect you to read it. It's really just to show you that there is a staging system out there which is used, I think it's used sort of clinically in terms of treatments and what have you, and research. It's also used quite a lot overseas, when actually what we're trying to do, if we don't have testing, then at least they can stage people by the sorts of symptoms that they're seeing. Okay? The sad thing is that obviously this would indicate much later infections, at which point treatment, if it was available, may still not have the sorts of effects that we want. So I say again, we are very lucky in the UK that we actually have a system and a process, which means this is a manageable chronic condition. Okay? And yeah, this is just sort of highlighting the realities of how these things fit together. In the UK, a lot of the HIV guidance comes from the British HIV Association, and if you're looking on the Moodle site, you'll see some of the links are included there. Just like the NICE guidelines for a lot of the other stuff that we do, the British HIV Association provides detailed information. How do we treat it? Well, we've already identified that there are potentially multiple ways of dealing with HIV based on its replication processes, and you'll see a whole series of ways in which this can be done. Often these are used in combination. But what are we actually trying to achieve? There are specific aims, because obviously HIV is not going to be eradicated. Once somebody has contracted HIV, they have HIV. In the past, that might have been dealt with, but okay, there is nothing we can do. Thankfully, increasingly in situations where in the past we thought there's nothing we can do, there's a load that we can do. Okay? Now, some of the treatments are very sort of medically focused, okay? But we have to remember that as nurses, we've got roles to play as well. Okay? So, supporting people in adhering to their medicines, adhering to their regimes, looking at ways of trying to minimise resistance through that adherence, trying to help people manage their side effects. And easy to forget, but hugely important, is that just maintaining good health. You know, we're talking about an immune system here, which is using the raw materials that we put into our own bodies. A good general state of health means an increasing chances of a good general immune system. And it's that immune system that we need to protect, okay? The individual as well, obviously. Okay, so that was sort of the sciencey bit. I appreciate, thank you very much for sort of bearing with me. What I'm going to suggest is that we draw things to a close now. Those of you in the room will have a lecture sort of to follow. Those of you on the video cast, thank you for joining us.